And here is your question. Please. Right. So if you have read and understood, considering it history taking station, kindly begin.
Okay, good afternoon. I am Dr. Muhammad, the treating doctor of today. May I confirm name date, please?
Yeah, yes, Mr. Muhammad, 42 UAL.
Nice to meet you, Mr. Muhammad. Today I've been asked to take a history from you. So how can I help you today?
Yes, actually, Doctor, 4 years ago, I had back pain, but unfortunately, 24 hours, the pain increased in the intensity rather than before. So we are here today to figure out this issue, please.
Yes, we'll do our best to do that. But let us me first a couple of questions. Would you mind?
Yeah, no.
Okay.
You can ask.
Can you describe for me the exact site of this pain?
Yeah, here in the lower part of my back, but actually recently it's radiating to my post buttocks, and was strange from away rather than the last pain 4 years ago.
Okay. And regarding, is there anything that increases pain, like exercise or decrease by rest?
Yes, actually was increasing with movement or just twist, and increase was extra work, and relieved was relieved by rest or just the usual painkiller. But recently the intensity increased and not relieved by painkiller.
Okay, and you said that it's now ready to your both to buttocks. And
Yeah.
what about the back pain 4 years ago? How it get different?
Yeah, it was a simple pain. The increase was the extra work commitments as I am employer in factory, and just on rest and taking just a painkiller as paracetamol. It was relieved. Uh, Otherwise, the recent one is a way different from this. This is the referred to radiate to my buttocks, and I observed that other issue.
Okay, you know that this pain is related to specific time during the day?
All the day now, all the day.
Not all the day. Okay.
Along
And Mr.
all
Hamad,
the
do
day.
you have any history of trauma?
No.
Okay. So do you feel there is a diminished sensation in your lower limb?
What is the next sensation?
Do you have any paresthesia in your lower limb, on your leg?
So actually, doctor, I have noted that I have like needles or numbness in my legs that is not present before. And
You have
also, I noted something strange as regard. I can't open my bowel. I'm sorry for that. I am pressed to say that, but this is a big issue.
no, it's confidential. My history is confidential, so you can speak easily.
And say, sorry to hear that.
Yes, I'm sorry to hear that. And what about your urine passage? Is there any problem with your urine passage?
Yes, yes. I have a difficulty in passing urine, just dribbling.
Okay. Do you have
Just
any tummy
24
pain?
hours. What?
Do you have any tummy pain?
No, no. There is
Do you
no
have
tummy.
Do you have any lower limb swelling?
No.
Okay. Do you notice that there is unintentional weight loss
No.
or loss of appetite?
No.
Do you notice that it increase the temperature of your body?
No, I don't know. I don't noted that.
Okay. Do you have any morning stiffness?
No.
Okay. What about do you take any medication rather than the analgesic?
No.
Okay. And do you have any drug allergy?
Just I have allergy for what's called penicillin,
Mhm.
but I had one attack for that. After that, I didn't experience any allergy to anything else.
Okay.
Yeah.
And do you notice that you wake up at the night going for to go to urine to go to the bathroom?
For water
No.
work.
No.
Okay. Do you notice that there is any semen or blood in your urine?
No.
Okay. So is there one? Do you have any surgery before?
No.
Okay. What about your family? Is there one in if your family have the same problem before?
No.
Okay. And what about your work?
Yeah, I am employer in the factory, as I told you, that I usually working in the factory, but I'm sorry to say that I was absent from my work due to this pain for about 1 week.
I'm so sorry for that.
Yeah.
I will liaise for a social people with
Okay.
you.
Can you present your case now?
Yes, today I take history from Mr. Muhammad, 40 years old. To
42.
complete my history
Yes.
examination, I would like to ask him about if there is if he smoke or drinking alcohol, and about his ID and the continuing expectation and other
Yes.
systemic manifestation. He is 40 years old, has back pain since 4 years ago, but it increased since 24 hours and radiated to both his back, to both his buttocks, and it's relieved by rest and some analgesic, and increased by movement. There is no any signs of motor or sensory loss in his lower limb, or as there is also no history of trauma and no signs of malignancy.
So
of
what
or
are your
trauma.
differential diagnosis?
I mean differential diagnosis. Maybe he has difficulty to open his bowel.
Yes. So these
Uh,
are some of the red flags that you're talking about.
the red flag is that he has difficulty in passing urine and
Opening bowel.
and yes, an opening bowel, and it is
Pain
but
is
he has
severe. Okay. So
yes.
what are the differential diagnosis?
So
What
main
can
differential
happen
diagnosis
suddenly?
may be sciatica.
Anything else?
I should also consider other causes such as spinal metastasis, but also lumbar disc herniation if there is any trauma, or maybe
Okay. How would you, Belvent? Okay. How would you confirm your diagnosis?
yes, I will confirm my diagnosis by doing a plain X-ray of the spine, of the lumbar spine, of the sacrolumbar spine, AB and lateral, and also MRI. I will do labs such as ESR and CRB, and
Okay. What management can you offer to this patient?
Management, I will management conservative management by doing by giving non-steroidal anti-inflammatory and doing some minimal and physiotherapy and hot fomentation, and that's all.
Yeah. Okay. Differential diagnosis. Anyone want to help Dr. Hamdi? In which situation? So problem was going on from 4 years. Yes, Dr. Moses.
Okay.
Lumbar.
Thank you. I was thinking the history is pointing towards acute disc herniation.
All right.
With CAUDA equina syndrome.
CAUDA equina. Yes, CAUDA equina.
That is what the patient has.
Yes. Number one diagnosis, provisional diagnosis is CAUDA equina syndrome. Number two is disc herniation. Okay. And then number three, because this is very important when you are telling the diagnosis. So what is the most common? You have that, or what this history tells you, you should have that number one. And then second number is the disc prolapse. And then what could be the third?
Spinal canal stenosis.
Excuse me.
It could
Not
be
exactly
No, no.
that.
all
Yes.
right.
Lerich syndrome.
Exactly, Lerich. Exactly.
Lerich. Okay, very good. Because when you are in the exam, you should tell at least 4 to 5. So what else can you tell?
Osteomyelitis of the spine. If the patient doesn't have fever, history taken, maybe that also have to be taken into consideration.
If patient could probably have metastatic carcinoma, what Dr. Hamdi told, one of that.
Tuberculosis of the spine.
Yeah.
Maybe non-spinal causes of
Yeah.
back. Yeah.
Yeah. Good. Okay. So if anyone
And
can tell
functional.
me, yes, sorry.
And the least possibility for this patient is functional due to
Yes,
the
mechanical
change of
back
the-
pain.
yes,
Yes, that could be
mechanical
the
pain.
least common.
The least one due to the change in the pattern of the pain away from the last
Yes,
one.
yes, true. True. Because here I try to give you the red flag signals. If I say this, now I want you to tell me 5 examples of the red flag signals, which can confirm you that this is CAUDA equina.
Red flag is saddle anesthesia,
Okay, and
saddle and motor weakness in his lower limb, and erectile dysfunction, and
age of onset.
and dysuria.
All right. Age of onset less than 20 or greater than between 20 and 50. So this is 42 years old, comes in that age group. And then urinary or fecal
Yes.
incontinence, leg weakness, sudden anesthesia, you said once, maybe a history of cancer, weight loss, or fever. Then there could be severe trauma or minor trauma in the presence of known osteoporosis. There could be progressively worsening pain that is not relieved by rest. So when you were taking history, you were asking all of these questions, right? You did ask all of these. You asked if patient has had any trauma. You did ask if patient has lost any weight. So you were asking in the right track. So when I asked you, I was surprised that you were asking right questions. But when it came to give me the differential diagnosis, you couldn't give me as I asked you. But one question, you did ask the patient what patient has for occupation, but you did not ask the patient to grade the pain between 0 to 10 and how cruciating this pain is, or how much it's affecting patient's daily life or activity.
Okay.
Patient itself was telling you that I've been absent from my work because of the pain. So yeah, so that was important. You did ask about fever and all those questions, even though when you couldn't ask about the eyes, but you covered most of the things. But it's the major thing, like that you have lost, or the grasp, you know, the idea, your idea that what you are trying to rule out, which diseases. So, yeah. This is hyper magnified, but it was taken from this article. And here you can see the problem. I just thought I'll give you one image. All right, started, and here is your question. Right, so if you've read and understood, considering it history taking station, can you begin?
Yes. Good morning. I'm Mr. Laziri, one of surgical Dr. Zair. Can I confirm your name and age, please, sir?
Yes, I'm John, 56 years old.
So, hi, John. How can I help you today?
Yes, doctor, I have like a swelling inside my mouth here, just right here, and it's increasing.
Yes, I'm really sorry for that. But if you don't mind, I will ask you some question regarding your issue, besides taking notes. Okay, do you agree with this?
Yes, sure.
Okay, so if you don't mind, can you point at the site of your swelling, please?
Yes, right here.
Yeah, from outside or from inside, please.
I felt it from inside.
So have you experienced any lumps or bumps from the outside?
No,
So have you had any trauma at this area before?
no.
Okay, when did it start, this swelling, please?
It started 6 months ago.
Okay, since have you experienced, is it a constant in size or increase or decrease?
I think it's increasing.
Increasing. So
Yes.
have you noted that did it start gradual or sudden?
Gradually.
Gradually. So have you had any fever associated with this
No.
swelling? Have you noticed that is there anything making it increase?
No,
Okay. Is there anything making it decrease or
No.
disappear? Okay.
Yes.
So it is usually present or come and goes, appear or disappear.
I can't look at it all the time, but I feel it inside.
So, okay. So have you noted that any change in your voice?
Yes, something like that.
Okay. Any difficulty in breathing?
No,
So any difficulty in swallowing? Have you noticed?
yes, maybe to liquids, to solid,
To
to
liquid.
solid, sorry, solid.
To solid? Yeah. For how long?
Since 2 months ago, or
2
1
months.
month, sorry, 1 month.
1 month ago. So have you noticed any change in your weight, Mr. John?
Yes, I have I lost about 2 kilo in last 2 months.
Last 2 months. I'm really sorry for that. So is it intentional?
Yes, no, non-intentional.
Okay. So have you noticed any change in your appetite?
Yes, I feel that I lost some of my appetite.
Yeah. So have you noted that any night sweating?
No,
Any night sweating. Okay. So have you noticed any tummy swelling?
no,
Okay. So any painful swallowing? Otherwise that's a difficulty.
no,
So have you noticed any lumps or bumps in all over the body?
no.
Yes. So now I will ask you some question, personal question. What's your occupation?
I'm working in a factory, a worker,
Okay. With whom at home you are living?
with my wife and children.
Okay. So do you smoke?
Yes,
How many packs per
about
day?
one packet daily.
Okay. Do you drink?
Yes, socially.
Socially. Okay. Just one thing I wanted to ask. Have you been told before from your GP or during childhood that you have unequal tonsils during oral examination or mouth examination?
I can't remember that.
You can tell me. So now, what's regard your family member? Anyone has had like this before?
No, I don't think so.
Do you have any medical condition?
No,
Any surgery before has been done?
no,
Any drug allergy?
no.
Do you receive any regular medication?
I only take painkiller for this.
Yeah. So have you been abroad recently?
No,
Okay, so to avoid miss anything, I will ask you some question. Do you have any headache?
no,
Any backache?
no,
Any muscle pain? Muscle
no,
ache? Okay. Any issue with bowel habits? A change in your bowel habits?
no,
Any waterworks issue?
no,
Okay. Any joint pain?
no,
Okay. Any chest pain?
no,
Any blurring of vision or issue with your eyes? Do you have any notes to be added, Mr. John?
no, thank you.
So what do you think is the cause of this issue?
Maybe cancer?
It's little bit early to say that. We need to arrange some investigation to rule out this. So what do you hope us to do, please?
I was usually remove this swelling.
Yes. For which are you more concerned?
For the change in my voice and the difficult and the swelling increasing in size.
Okay, you can
Yeah, I
present your
promise
question.
to figure out your issue. Thank you for your time. I'll best my notes to my concern to figure out your issue. Today, I took history from Mr. John, 56 years old,
Yes.
who is presented with right tonsillar swelling 2 months ago, gradual onset progressive course with no associated increasing or decreasing factors of this swelling, no history of fever or
Yes.
trauma at this area, with no history of lumps or swelling all over the body or at the neck. He complained of a change in the voice at the same area and the difficulty in swallowing, especially to the solid food. About 1 month ago, he had a significant history of weight unintentional weight loss, about 2 kilograms
Very
over
good.
the last
Yes.
2 months, and decrease in the appetite. Okay, with no other significant history. So my top differential diagnosis will be malignant swelling of the tonsil in form of squamous cell carcinoma, but I will consider other causes in form of non-Hodgkin lymphoma and also chronic infection in form of infectious mononucleosis, TB, or chronic non-specific infection of the tonsil, and also, but the least common is congenital unequal enlargement of the tonsil.
What investigations would you ask for to
So
confirm
as
your
regards to
diagnosis?
patient, the most I will order lab and imaging, but the most important I will start by pen endoscopy in form of visualization upper pharynx, upper larynx, esophagus, and trachea, and the CT abdomen, CT neck with IV contrast, and will consider lab investigation in form of quantiferon chest X-ray, ESR, CRP, and full blood count, urea plus liver function test.
Right. What
PT
treatment can you
bit
offer?
or the body. Yeah, what?
What treatment can you offer this patient?
Yes, I will offer after discussion with MDT team excision of the tonsillectomy radical with radical neck dissection or modified or selective removal, followed by chemoradiotherapy according to the MDT decision. And if the patient is inoperable, will need feeding access in form of jejunostomy and palliative therapy in form of painkiller and radiotherapy.
Good.
Yeah.
This was good because it was easy, I guess.
Okay.
Yes, and here is your question. Right. So if you have read and understood, considering the communication station, kindly
Yes.
begin. Communication station.
Good afternoon. I am Dr. Muhammad, one of the surgical doctor. Yes, may I confirm named age, please?
Good afternoon, doctor. I'm Mr. Max, 66-year-old man.
Yes,
Good.
Mr. Max, nice to meet you. So what do you know so far about your condition?
Okay. I've been having painless bleeding from my back pass and weight loss since 2 months ago. So my consultant asked me to come today.
Yes. Firstly, I'm so sorry for that. After discussing with my consultant, we would like to do to you what is called the colonoscopy. Do you know what is colonoscopy?
Sure, no problem. But from what I gathered, the consultant, Mr. Roberts, wants to use a camera to look into my bowel to see where the bleeding is coming from.
Yes, let me discuss to you more what's colonoscopy. It is like a tube. It is like an imaging which can be introduced through to your tummy and intestine in your tummy. It relay an image on the TV screen, so we can look at if there is any look at the source of the bleeding, and we can also take a sample from it to rule out the diagnosis. Is that clear?
Okay, yes. But it seems it's not pleasant. Will I be awake during the procedure?
Will what?
Will I be awake during the procedure? I will know when you are doing it. Awake.
Awake. Waken up.
Wake up, as in I will know when you are doing it. Awake.
I can't get this.
Okay, I'll write here.
Okay, is there any other alternative then to this procedure?
What I can say?
Yeah, sorry.
Wake.
Awake.
Yes. So yes. Okay. Okay. Actually, yes. There will be we will give you you will be awake during these procedures. We will give you a gel locally so that you can't containing a painkiller that so you can't feel pain during the procedures.
Okay.
Are you comfortable with that?
Yeah, but is there any other alternative? Are there alternatives to having this colonoscopy?
Any other alternative?
Alternative? Yes. Yes, there is another alternative. Actually, I appreciate your concern, and it's your right to choose any other imaging, but it's this colonoscopy, the colonoscopy is the leading for us to get a diagnosis or to reach a diagnosis for case. But there is another imaging like doing a CT or MRI. But I recommend doing this first, as it will help us to reach a diagnosis, and also we can get a sample from inside your tummy to reach a diagnosis. Okay, is that clear?
Yes, all right. So I will have the colonoscopy then. Are there any risk associated with the colonoscopy?
Yes, there is no any procedures without risk. There may be bleeding. We can get there may be bleeding, or maybe skin injury during entrance, or the most risky is that we can injury you can get injury inside your tummy, which this may need operations to repair. But who will do it is an expert enough. So so this complication doesn't mean that it may occur. It may occur. Okay.
Thank you. Then can I eat and drink as normal before the colonoscopy?
Actually, you will get you can drink only, and some minimal amount of water, but you should stop eating around 12 hours before doing it, so that it can help us while visualizing inside your tongue.
Okay. Okay.
To avoid the presence of any gases or other like that.
Okay. Okay. Then can I take my BP medications in the morning?
Which medication?
Blood pressure.
My blood pressure medication.
Blood?
Yes, my hypertensive.
Blood thinners?
I'm hypertensive, so I'm on antihypertensive drugs. Can I take them in the morning of the procedure?
Yes, you can take your medication as minimum amount of water.
Okay. What about the aspirin? Because I'm using aspirin also.
Aspirin, blood thinner, yes.
Yes, yes. For the aspirin, we will monitor your INR, and you should spot it, and you will monitor your INR so that to.
Hello, Dr. Rami.
No.
How did you test the lingual nerve?
Sorry. Okay. This you will ask the patient to stop 7 days before.
Yes.
And restart immediately after the procedure.
7 days?
Yes, before.
Okay.
And anything else? The last question. When will I get my results?
Yes, when will I get my results of the tissue sample taken?
Yes, we will get the results within 1 week, and I will inform you I will call you once the result is available.
Okay. All right. Thank you.
Thanks.
And in the last, Dr. Hamdi, you tell the preparation 4 days before. What would you have to do? How would you prepare the patient?
So yeah, now you can you consent for this this procedure?
Okay, no problem. I'll sign the consent.
Consent, good. Okay. And there was 2 seconds left. In that, I asked you to tell the preparation. So 2 seconds left.
This is a new one also, right?
For you, yeah, we haven't done that. So there are preparation like 4 days before you'll stop iron constipating drugs or bulking agents. And 2 days before you'll eat only eggs, cheese, white bread, butter, no meats, fish, fruits, vegetables. And 1 day before, breakfast with all the above. Then clear fluids like tea, coffee, and fruit juices. And at 3 p.m. before the procedure, just a half glass of water, and then yeah, on the day of investigation, day of colonoscopy, you have to yeah, so this you have to tell. And then yeah, I told you when you were telling the risk factors, so there were 4 actually. You told two very nicely, but then you forgot to tell first the sedation one, and then you told the second bleeding one, and then the perforation, and then the third is when it is incompletely done. And the alternative, you said it can be CT or MRI, but here alternative is barium enema. And
Barium
why
enema.
barium enema cannot be the useful alternative? Because you cannot take the tissue sample. You did say that, correct, but you mentioned
Another
and
barium.
MRI, yeah, other images. And then here this when you were explaining what colonoscopy is, you said it's an imaging. It's not an imaging. It's a camera, and you have to tell that how big that is. 2 pence. It's a coin in UK. The size of camera is 2 pence, as big as the 2 pence. So you have to give that example. That how big that is, and it's like an endoscope that you put in from the back passage. So explanation was not correct. So once you'll go back and read this topic, you'll realize the things that you couldn't answer correctly. So started, both of you, and here is your question. Who is going through the notes? Okay, so if you're ready and if you have read and understood, kindly begin your communication skills station.
Yes. Hello, I am Mr. Mohammed, one of surgical registrar here. I just want to call ITU registrar in charge today to ask him about preoperative advice and for possible post-operative ICU bed, post-operative for inpatient. Can I check that I'm speaking to ITU registrar in charge today or not, please?
Yes, summarize your case.
Good.
Yes. Hello, just we have 76 years old lady. She attended to our A&E department complaining of sudden abdominal pain. As regard on clinical examination, she is slightly drowsy, and his clinical examination of her abdomen is suggestive of acute peritonitis or perforated viscus. She needs urgent laparotomy. She has a background of COPD, and she is on steroid. So what I want to ask you about your preoperative advice for preoperative optimization before calling our anesthetist. And I will ask also for possible postoperative ITU bed. So what do you think about this, please?
Okay, why do you think it is a perforated viscus?
So as regard the patient came hemodynamically unstable, and also his symptoms and signs of abdominal examination denote peritonitis or perforated viscus. and the chest X-ray was done, revealed just air under the diaphragm. I checked from the patient notes. Additionally, lab investigation was done, revealed metabolic acidosis and hypokalemia, beside drop of hemoglobin by 2 grams below the normal level. So this is suggestive of perforative viscus and complicated by generalized peritonitis.
Good.
Okay, so what's the fluids resuscitation will you do for this patient?
Yes, as regard as Chris protocol ABCD approach, we'll start by fluid challenge, start fluid resuscitation by at least 2 liters of crystalloid. If no response, I will go through colloid. And as regard, I will start to cross match for blood transfusion for further ongoing operation the patient will need. And as regard, due to this is old age, I must consider follow-up of the central venous pressure and urine output to avoid overload or dehydration or minimal resuscitation of the patient.
Okay, what are the preoperative management you suggest?
Yes, as regards this patient, I will consider start IV fluid resuscitation for the patient by crystal, as I mentioned before. And the most important, I must correct, I will order also ECG to detect any AF for possible appearance of AF due to hypokalemia and electrolyte disturbance. I will also correct hypokalemia according to the reference range. The patient also will need to put it in IV steroid to avoid Addisonian crisis at the patient on steroid, and she is going to be operated now to avoid Addisonian crisis from the surgical stress. And also I will give the patient antibiotic and the proton pump inhibitor to avoid any stress ulcer. And they will ask the anesthetist consultant or registrar in charge to come for perioperative optimization, considering also putting indwelling caster to monitor urine output and also central venous pressure. Yes.
Yeah. So what are the criteria of ITU admission? You know?
Yes, as regards the criteria for this patient is borderline to be in acute renal failure due to elevated creatinine and urea, and that the patient is COPD patient. So the one chronic disabled organ, and there is one is going to be impaired in form of the renal. The other criteria, if the patient need one-to-one nurse caring, and also the patient needs cardiac support in form of inotropes in case of delayed sepsis, septic shock. And otherwise, if the patient which is drowsy may need respiratory support just in form of the invasive one, in form of intubation, or non-invasive mechanical ventilation. Okay.
Okay. What is the type of oxygen mask for COPD?
This patient is COPD, so I will put on about 24-28% to avoid the oxygen drive interruption. And by inventory mask, I will put this patient in this oxygen saturation put the patient with baseline EPG. Then I will monitor EPG further on oxygen mask.
What type?
Okay, regarding
what type of
mask?
Venturi mask.
Okay.
Regarding the potassium deficit, can you calculate how is the potassium deficit?
Yes, as regard regarding the level of the potassium, if the level is below than 3 millimole per liter, I will give the patient at least five ampoules of potassium chloride and monitor hourly. And if the patient the level, I will check after 24 hours. If the level between 3.5, I will give the patient 3 doses of potassium chloride, monitoring hourly, and will reassess after 24 hours according to the deficit of the potassium level.
Good.
Okay. What if only you have one ITU bed left and there is an asthmatic young lady coming first?
So as this, I can arrange with our anesthetist registrar and communication with your side. I will follow the patient in the recovery room assuring the patient is stable until your bed is be ready after discharge of your of the lady which is asthmatic, as she in need to this bed. After that, we can shift the patient in cooperation with you.
Okay, I will manage an ITU bed and call you again.
Okay, so do you have any other recommendation or piece of advice for preoperative optimization or for any arrangement?
No, I will manage an ITU bed, a free ITU bed, and I will call you again.
So if you don't mind, please, when it is ready, can you update me? And I will notify our anesthesia registrar in charge that will be available as you notify me. And after that, we will run our operation. Thank you for your time.
Okay,
Good.
thank you.
Thank you. Thank you, both of you. Right, good.